wanted to share with you this morning was really to, and it's actually rather nice that Suzanne went first, because in a way this talk belongs just right behind Suzanne's. What we're looking at here is, in fact, the concept that there are guiding principles, so there is indeed a guiding principle, but I would argue actually that obviously one size does not fit all when it comes to our actual practical application, but perhaps there are some key sort of takeaways that we can give you and what we need to know about triplets, doublets, quadruplets in the upfront setting, and sort of drill down to a very practical view. Now, Suzanne very kindly covered risk, she covered maintenance, which is critical, and obviously gave you a flavor of some of the induction remission strategies as well as some of the transplant data. In the interest of time, I'll move through those very quickly then to avoid duplication, but I hope to bring you some new data that's a little different to what she showed that hopefully will guide you, particularly in frailer and older populations. So as we all know, myeloma, not just one disease, and obviously we individualize treatment. So in a sense, this is my counterpunch to the title. Obviously one size does not fit all, but we need to think about basic principles, not least of which to overcome clonal heterogeneity, which is a big problem, and summarized on this slide, recognizing that treatment pressures contribute to it as well. Now, I showed you this earlier, but I'll just show you in bigger vision now to really give you an eyeball on it. This is actually lovely work from Nikhil, my partner at Dana-Farber, and leads our correlative science effort. And Nikhil does fabulous work in genetics. And as you can see, over 5,286 mutations in this setting. And then when you see this patient relapse after induction remission treatment, transplant, and maintenance, we're way over 12,581. So a daunting task. Clearly, a big net needs to go around this process. So in that spirit, I borrowed this slide, actually adapted it from Ivan Borriello's review a few years ago. So I think it's a really nice slide. I mean, remember that it's a marathon, especially with the Boston Marathon coming up on Monday. This is prescient, and certainly not a sprint. And that in that context, we have to recognize our induction remission strategies and what we do to maintain remission, and what first relapse and second relapse all start to really matter as we think about the continuum of therapy. Obviously, we think about transplant versus non-transplant patients, and I would argue that that distinction is becoming much more fluid. Younger patients, older patients, these are all dynamic spaces, and I would argue that there's induction remission treatment, some form of consolidation strategy, and then some form of rational maintenance that augments efficacy and at the same time does not add to acute toxicity, late toxicity, and most importantly, this is perhaps a novel concept, also doesn't exacerbate genotoxic injury in every way that that means. This is a highly mutationally unstable disease, so any drug that further amplifies mutational instability seems to me to be one that we should approach with a certain amount of caution at least. Now, in terms of that, what about basic principles? Well, you heard a little bit about this earlier from Suzanne. I'll just re-emphasize it. I think it's now clear from randomized data that triplets are preferred. Doublets are less commonly used, but appropriate, obviously, in selected patients. And I won't dwell on this, but maintenance really matters. And I especially want to acknowledge data that's emerging to show the benefit of very well-tolerated antibodies like elotuzumab, for example. And we're looking forward to hearing more about DARA in this space. But ELO is one example of being yet another addition to the armamentarium in the maintenance setting, as well as ixazomib. And I'm going to spend a little bit of time on IXA in a moment. Induction remission strategies, the triplets are well established. This is just representative examples. One message from this is the addition of chemotherapy to these platforms didn't really do very much. Obviously, novel therapy is a different story. And of course, we've moved into this space now of very exciting combinations, in particular carfilzomib Lendex. I'm going to show you data from both that and IXA-RD, as well as, obviously, the real excitement around antibodies. But again, Ed's going to come to those in more detail in a minute. Suzanne already touched on this, but this trial, obviously led by Brian Drury, was critical in establishing that RVD was a new standard over RD. In transplant patients, a paradigm of thinking is summarized on this slide that we showed at ASBMT, and I think it absolutely stands. And there's no question that in the younger patient, autologous transplant is and remains a standard option in their management. In our practice, it's certainly an option based on the data that we have. And why so? Because essentially, as Suzanne mentioned, There's no overall survival difference despite a PFS difference for early versus late transplant. One critical point to understand about the French and US determination study is it's not a test of transplant yes or no, it's a test of transplant early versus late. And that's, I think, a key point to take away. And as Suzanne very kindly pointed out, the IMID exposure for the French trial was just 1 year. In the US trial, where the event rate has been really encouragingly low for both arms, it's until progression, and that probably makes a big difference. What's also very important is data that was presented by Hervé Avalé-Oiseau at the December ASH meeting, where if you achieve MRD negativity on our trial, however you do it, the outcome's the same. That's an incredibly important point, because what it tells you is that RVD alone achieves MRD negativity with or without transplant. Obviously, with transplant is a higher rate, so that's good news, but at the same time, if your patient achieves our MRD negativity, certainly in this clinical trial context, the outcomes are the same. So with that in mind, where are we going? Well, again, you're going to hear more from Ed in a minute about antibodies, but I'll be quick as I go through this. Triplets appear to be the new standard. I just want to touch briefly on IRD data. This is from Shaji Kumar, and it shows that weekly IRD is very active and well tolerated, particularly attractive, arguably, in an older patient population. And I think we're obviously looking forward to the randomized trials to support this approach. I do want to show one thing which is very nice from Shaji's trial, quality of life assessment. It's excellent with this approach. When we doubled up on the ixazomib, because there's this concern that once a week may not be enough, you need more, and we showed basically a very attractive complete response rate, and overall response rate was actually very importantly improved. The maintenance to mention was IXA alone, so that's an important point here. But having said that, again, in terms of a durable PFS, it was there. These were sicker patients than in the weekly population. And in that same context, in this phase 2 study, we saw nice quality of life. Now, this pooled information was presented by Thanos Dimopoulos at ASH in December. Just suffice to say, ixazomib seems to be a real addition to our armamentarium, not only for the point of view of an induction remission treatment, but also as an excellent maintenance agent. I also want to especially acknowledge Philippe Moreau's work with IXA pre-transplant in a very organized and focused fashion. The weekly data are very interesting because what they show is over time things do really well, and particularly here if you look with maintenance. And he's now taking this into the twice-a-week setting with ixazomib to explore that further. Now, carfilzomib, as you heard so nicely from Suzanne, is a step up. It's driving higher quality responses. It's getting MRD negativity at a higher level in combination. And really seminal work led by Todd Zimmerman and Andres Jakubowiak has explored this. And I think further studies obviously are in process in a variety of different settings. But in a nutshell, very high quality responses, very durable as well. One caution, of course, is the vascular toxicity of carfilzomib. And we need to know how better to manage it, because it's not just cardiac, it's also thromboembolic, HUS-TTP, it's microangiopathic. There are a variety of strategies, fortunately very rare, thank goodness, but an important one to bear in mind. Adding antibodies to this, of course, takes it up a notch even further, and that's proven very exciting. So again, high qualities of responses in all respects, and durable responses to boot. So a very exciting platform. So principles, 3 drugs, and then, of course, the emerging role of antibodies. Now, in the interest of time, I'd actually asked my partner, Jacob, to get me his slides on RVD-ELO because he's led that work beautifully. Unfortunately, they didn't get to me in time for today's presentation. But combining RVD-ELO has also been very promising in this setting. So elotuzumab as an induction remission strategy, or as part of it, has been very important. And again, we're looking forward to phase 3 data in that regard. Now, what about in the older population, the integration of antibodies? Well, a couple of points to make here. Of course, we have the platform or pivotal trial, I should say, from Mari V. Mateus, combining DARA with bortezomib, valproic, and prednisone. VMP is not a regimen, obviously, we use much in the US, but obviously it's worth acknowledging the critical nature of this work, because essentially it provides really the segue for FDA approval and certainly regulatory approval outside of the US for this combination. This was the design of the trial, VMP for 9 cycles versus DARA VMP. A critical difference was the use of maintenance DARA. I think that's obviously vital. Personally, I think the vulnerability in this trial lies in that, because obviously this control arm, certainly in the US, given what we know about maintenance, would not be considered an adequate standard. So let's bear that in mind. That notwithstanding, the results are very striking, support the role of the antibody platform being integrated into an induction remission strategy going forward. So what was also very interesting for Mary V's work was the MRD studies, really showing benefit to that approach in terms of the antibody. And so her conclusions really are summarized here, that essentially the use of an antibody plus a triplet as a standard of care in transplant-ineligible newly diagnosed myeloma is certainly justified on the basis of this phase 3 data. Now, what about sort of doing things more gently? Well, I think in that spirit, I did want to profile some really nice work from my colleague Betsy O'Donnell, and especially acknowledge my partner Jacob Laubach, who's led this with her. This is the so-called RVD lite regimen. And this was built on the original IMiD proteasome inhibitor steroid platform with the goal of potentially adding other drugs to it, such as antibodies, and I've already mentioned Jacob's work with elotuzumab. But that notwithstanding, I want to show you the core data here because they're very interesting. This is the induction strategy, 1 to 9 cycles every 35 days, and basically the bortezomib is administered weekly. The lenalidomide, to Suzanne's point earlier, is given at low dose 3 weeks on and then a nice 2-week break off. Dexamethasone is partnered, but of course cautiously in the elderly. One key message to take away from a practical point is always to partner your dexamethasone on the day of bortezomib and the day after when you can, because that reduces neurotoxicity. And another observation we've made is that partnering intravenous hydration with normal saline with bortezomib, even if you go sub-Q, matters. It reduces fatigue, and we have a rationale for it and cohort studies to support that it actually reduces neuropathy even further. So worth remembering that. In terms of consolidation, they're summarized here. So what Betsy's primary endpoints are summarized as follows: the overall response rate. Secondary endpoints were to look at safety, PFS, OS, and at the same time to look at pharmacokinetics. The first group of patients were given IV Bortez and then a much larger cohort sub-Q. These are the eligibility criteria. As you would imagine, an older population who are not eligible for transplant. These are the patient's baseline characteristics. So 73 patients strong. Oh, sorry, I apologize. Median age of diagnosis, I'm sorry. It's the total number of patients, I'm sorry. My eyes are deceiving me, is 50. And then basically the median age is 73. But I just want to bring your attention to the oldest patient, who was 91. So what did we see? Well, basically the overall response rate was very solid at 86%. But what I want to bring to your attention is the VGPR or better at 66%. So we felt this was really quite encouraging for that. And this is particularly interesting that with this approach in this population, almost a 3-year progression-free survival, very similar to the classic RVD arm of the SWOG trial. So this was, we thought, very compelling. The overall survival, the median has not been reached. And in that context, the safety has been excellent. As you can see, the rate of grade 3 neuropathy is just 2%. And this is an elderly, vulnerable population in whom neurotoxicity would be expected to be more. So very encouraging in that regard. In terms of the serious toxicities, they're summarized here. But what you should know is that obviously they were relatively rare, fortunately. And apart from the neuropathy signal, which is illustrated here and remains important, but certainly manageable, what you can see is that dose modifications occurred in the majority of patients, but the rate of actual discontinuation was actually encouragingly low. And most of the dose modifications were for steroid, half of them for lenalidomide, and 40% of them for bortezomib. So we think this is a really encouraging approach going forward. And importantly, in this study, the rates of cardiac or other vascular toxicities were minimal. We just didn't see them. These are the quality of life assessments that look really good, very important to do in the elderly population. I especially acknowledge Betsy because that was hard work. So her conclusions are here, that this is a well-tolerated platform, the response rate's encouraging, and the median PFS of 3 years in an elderly vulnerable population is remarkable. So what about future directions? Well, I want to acknowledge the work of Peter Voorhees, who's leading RVD DARA in stem cell transplant patients in the Alliance. This is work going forward and is actually fully accrued. Pete presented this as an abstract at ASH simply acknowledging the safety profile, I can report that the study in record time has accrued and actually finished ahead of schedule. There's also superb work led by Philippe Moreau and the IFM looking at VTD plus daratumumab in transplant-eligible patients going forward. And in that context, it's worth noting that as we think about the principles of what we do in induction remission therapy for myeloma across the board, I want to sort of conclude with these last few closing comments. That a PI plus an IMiD plus DEX is a platform. And these range from RVD to KRD to IRD to RVD lite. We believe that the highly efficacious triplets are preferred over the doublets. The antibodies are very exciting. I've obviously spoken a lot about daratumumab. Again, I want to emphasize that ELO has a role, and in my experience is actually undervalued for what it does. In terms of emerging as key additions, these are vital going forward, particularly not only in induction, but also in maintenance. And we've already talked before about the evolving role of transplant. Clearly, in transplant-eligible patients, it remains a standard of care. Early versus late, I think patients truly have a choice because there's PFS benefit, but no OS advantage, to date at least. Now, I think you'll hear more about the value of tandem transplant, and that's a separate point, but just to acknowledge that in the advent of antibodies and other new strategies, where tandem belongs, of course, is a moving target. And I would just make a point that we need to be very aware of acute and long-term toxicities from what we do in that setting. And just to echo points made by Suzanne earlier, maintenance is essential. Lenalidomide on the back of autologous transplant in the in the 100-104 trial led by Phil McCarthy, that's the Alliance study. The median overall survival figure is now approaching 10 years. So this is really important. It really shows that this matters. That data was just published in The Lancet by Sarah Holstein, but when you hear that, you realize 10-year median survival with maintenance post-transplant with lenalidomide until progression. That's, I think, incredibly important takeaway. And then, of course, the antibodies are going to build on this. And, of course, MRD as a research tool will hopefully help us going forward. So at that point, I just want to especially acknowledge how all of this happens, because I think it's always worth emphasizing, in particular, our pharma partners, as well as our advocacy groups, and, of course, our regulatory authorities as well. And this is no accident. And finally conclude to say thank you.